So we'll go ahead and get started. And I'll just start out by introducing, if you're unfamiliar with Maryland Behavioral Health Integration in Pediatric Primary Care, my name is Rebecca Farrow. I'm a member of the BHIPP team. We call it BHIPP for short since it's a long name. I'll be introducing our presenter for today and facilitating our Q&A session at the end. If you do have any questions during the session, feel free to pop those in the chat or the Q&A, whichever's easier for you. And then please feel free to have those questions at the end as well. So for those of you that are unfamiliar with BHIPP, we can go ahead and go to the next slide. I'd like to provide some information about our program. So we are a child psychiatry access program that supports the ability of pediatric primary care and emergency medicine professionals to address and manage mental health concerns. BHIPP is a free statewide program that offers telephone consultation, resource and referral networking, care coordination, telepsychiatry, telecounseling, and training and educational opportunities like this one. The BHIPP Warm Line is staffed by a team of child mental health specialists and is available Monday through Friday, 9 a.m. to 5 p.m. And we'll put our phone number and website information in the chat for you. So it is my pleasure to introduce our BHIPP Resilience Break for today, Avoiding Provider Burnout. And this is presented by Dr. Marianne Booth. Dr. Marianne Booth received her medical degree from the University of Maryland and completed her psychiatry residency and child and adolescent fellowship through the University of Maryland Sheppard Pratt Combined Program in 2010. Since that time, she has worked in a variety of mental health settings, including alternative education settings, federally qualified health centers, outpatient mental health clinics, and providing consultation to primary care providers. Special areas of interest include telepsychiatry, anxiety disorders, and autism. So we're very grateful to have you here today, Dr. Booth. Thank you for sharing your expertise with us during this session. I'll go ahead and pass it over to you.
Okay, thank you. I can get the slide up.
And there's just our information on our funding. We are state funded.
So my disclosures, I am a physician with the BHIPP TAP program, as Rebecca had said, and I have no conflicts of interest. So the objectives for today's talk is to define 3 to 4 risk factors for provider burnout, identify 3 internal strategies or coping mechanisms to avoid burnout, and identify 3 external strategies or coping mechanisms to avoid burnout. So a lot of my colleagues send me memes. They call it Meme Monday. And for any Starbucks lovers in the audience, this one says, you said you expected more from Starbucks. We have here the tall, the grande, the venti. We listened, introducing our newest coffee size, the overworked physician. And of course, it looks like a big bucket of ice cream, but it's coffee. So just to add a little levity to our discussion today. So before we talk about treating burnout or avoiding it, we have to talk about defining it. It was first described in 1974 by the psychiatrist Herbert Freudenberger. It's defined as a state of mental and physical exhaustion caused by one's professional life, and it's distinct from other psychiatric illnesses and depression. It's caused by social conditions, in particular, excessively striving to reach an unrealistic expectation imposed by oneself or by the values of society. And it begins with a gradual emotional depletion and leads to a loss of both motivation and commitment. It is both a state and a process. So the MASLAC Burnout Inventory is the most widely used inventory or measuring tool to measure burnout. It's primarily a research tool. It's a 30-item research tool. It's actually copyrighted, so I couldn't put it on my slides today, but I did pull some of the items that it asks about, such as, or screens for, such as I feel emotionally exhausted because of my work. Working with people all day is stressful to me. And items such as I feel worn out at the beginning of the working day. And it's quantified by how often an individual experiences these feelings. Other measures of burnout are the Oldenburg Burnout Inventory, the Copenhagen Burnout Inventory, and the Physician Work-Life Study Single Item Questionnaire. So burnout has been identified along all career stages of medicine, from medical students to residents to practicing physicians. The burnout rate is estimated to be approximately 50% amongst U.S. physicians and medical students. Unfortunately, a lot of the studies do not report data by gender. Those that do have found that burnout is experienced by and manifests itself in men and women differently. As measured by the MBI, the MASLAC, women physicians are more likely to suffer from emotional exhaustion, whereas men are more likely to describe depersonalization. Regardless, surveys have found that the prevalence of burnout may be as much as 20 to 60% higher amongst women physicians than male physicians. So alarming signs that burnout is on the rise. Out of 7,000 physicians, and this is from a survey by Doctors Company in 2012, but only 1 in 10 would actually recommend a career in medicine if they were to do it all over again. In this same survey, half of primary care physicians age 50 and above actually plan to leave their medical practice in 5 years. And 30% of primary care physicians ages 35 to 39 plan to leave their practice in that same time period as well. Contributing factors to burnout, some of these may not be surprising, such as workload, work hours, administrative tasks, increased responsibilities, things like having children at home, work-life integration, decreased support, sexual harassment, and real or perceived lack of fairness in promotion. Specialties with the highest rates of burnout, and this is from a Mayo Clinic study in 2017. Again, some of these may not be super surprising. Emergency medicine makes the list, OBGYN. Our family medicine colleagues and friends also make the list. And then also some other ones, radiology, physical medicine and rehabilitation, and internal medicine subspecialties as well. Some reasons for this that have been postulated with, for example, our radiology friends is with the advent of the electronic medical record and less dialogue. It used to be that on medical rounds, you would make the rounds and then go down to the basement to read the films. But in some hospital settings, this isn't happening so much anymore. The reports are just sent via the EMR. You can pull up the radiographs in real time, and there's no trip down to the basement or where the radiology wing lives to actually consult with our radiology colleagues. So this slide is looking at physician occupational burnout, depressive symptoms, career satisfaction, and work-life integration by race and ethnicity. It's a little bit of a busy slide. It's from JAMA Open Network 2020, so it's fairly recent. Interestingly enough, burnout was observed in 44.7% of white physicians, 41% of Asian physicians, 38.5% of Black physicians, and 37.4% of Hispanic physicians. Possible explanations for these results could include the stigma associated with disclosure of burnout symptoms, poor retention of medical students in minority, racial, or ethnic groups, and residents who experience burnout, differences in personal resilience by race and ethnicity, or a selection process that favors resilience among minority, racial, and ethnic groups during medical training. So, special stressors for women providers. Women have a 1.6 odds of reporting burnout compared to men, and this burnout significantly increases with working more than 40 hours per week. And this statistic is from the Journal of General Internal Medicine from the June 2000 issue. There may be a perceived stigma towards part-time work and taking time off of work. Child rearing and family responsibilities, having children can slow career progression of women in academic medicine. Women on average work more than male physicians with children, averaging 90.5 hours per week versus 68.6 hours per week. And women with children are often subject to micro inequalities. A micro inequality example is that Dr. X is paid a reduced salary for working part-time by not being eligible for additional perks that full-time faculty receive, but she is also working during her off time, checking the computer, looking for labs, and doing medication refills. Both men and women report that challenges in work-life integration contribute to burnout. Depression has been reported as early as 6 months into the first postgraduate year and is more common in women than men. Gender-related bias seems to be even more prevalent among women physicians who are mothers. In a survey of an online group of physician mothers, 1/3 of respondents noted experiencing discrimination related to their role as a mother. Exposure to maternal discrimination was associated with an increased incidence of self-reported burnout. So workplace factors that may predict burnout include, unsurprisingly, the workload and the changing complexity of patients. The fact that patients have gone from having a few problems to possibly 10 to 20 medical problems on their problem list. There were fewer diagnostic tests in the good old days, or in the old days, and that preventative protocols have become more complex and are ever changing. So also the degree of control that a provider or physician has. Small practices have given way to more hospital-based groups. And I personally know very few physicians that still own their own practices. They're usually in large hospital-based groups. Control of the work environment, the practice setting, the days and hours worked, the length of appointments, the rooming procedures, the compensation models, flat salaries versus relative value units, performance bonuses, and the loss of that community feeling in a hospital. The trip to the radiology wing in the basement of the hospital and the rounds is not always done anymore. And finally, the congruence between the provider's values and those of the administration that they're working in. Additional signs of burnout at an organizational level, warning signs, include things like high staff turnover, vacant positions, disruptive physician behavior, lack of physician engagement on strategic projects or improvement work, refusal to see additional patients, lack of attendance at medical staff meetings, and angry complaints about EMRs. Oops. From a systems perspective, causes of burnout may include changes in reimbursement models, regulatory policies themselves, shifts in patient demographics. We're dealing with an older patient population now, and advances in technology and treatments. The practice of medicine, I think we can all agree, has become more stressful with science and technology advances and now new political and economic climates in healthcare as well. I wanted to focus on a couple other topics that may increase burnout. One is debt as a stressor for burnout. This statistic is taken from the American Medical Association from 2015, that the average amount of medical education debt is $180,000 a year. Obviously, it's increased since 2015. One hospitalist who chose to leave medicine has said this about her debt. I thought when my residency ended that there was a light at the end of the tunnel, so I kept going and going, and then I realized it was a train coming for me. I wanted to talk for a few moments about imposter syndrome and burnout as well. Some researchers have found a relationship between the presence of imposter syndrome and conditions such as anxiety, depression, and lower self-esteem and burnout, especially amongst women. So imposter syndrome or imposter experience is a pattern of thinking and behavior exhibited by individuals who cannot internalize their own successes and have a persistent fear they don't deserve what they've achieved, despite evidence to the contrary. A study of imposter syndrome amongst medical students at one U.S. institution found it to be present in 49% of women and 23.7% of men. Medical errors can be both a cause and a symptom of burnout and mental health suffering. So when as a cause of burnout on this slide, subsequent symptoms once a medical error has occurred, that can happen in the provider include anxiety about future errors, loss of confidence, sleeping difficulties, and harm to one's reputation. The consequences of burnout are many, but making the top of the list, dissatisfied physicians and other providers are 2 times more likely to cut back or leave the practice within 2 years than more satisfied colleagues. Burnout and physician distress, it can become a risk factor for alcohol abuse or dependence issues. Burnout, depression, and fatigue are significantly associated with a motor vehicle accident, and this is from a 2012 study of residents. Burnout is associated with a reduction in cognitive functioning that can be seen on functional MRI. And this is a study by Golkar in 2016. And burnout itself is associated with making more medical errors. So burnout and depression are independent predictors of reporting a recent major medical error. And this is from Shanafeld in 2010. I wanted to spend a moment talking about burnout, depression, and suicide. So they're separate, but they're related entities. It's very important to distinguish between them because their remedies are different. Burnout is situationally specific. It's related to the workplace. Depression and suicidal ideation can occur in some physicians suffering from burnout, but typically reflects the presence of additional issues. This next slide is looking at suicide and physicians. So the death rate of physicians is lower than that of the general population for every major cause, including coronary artery disease, stroke, cancer, and respiratory disease, with the exception of suicide, which is much higher. Doctors have the highest rate of suicide of any profession. Male physicians have a 1.4 times higher rate than the general population, and females have a 2.3 higher rate than the general population. Possible causes for this may include undiagnosed and untreated depression, inadequate mental health treatment, and problems related to job stress. So in the book, Preventing Physician Burnout, Curing the Chaos and Returning Joy to the Practice of Medicine, the authors pose a question that I think is really important. They say, is provider-physician burnout a systems issue or more of an inherent issue in the person themselves due to the stresses of practice, the traits of physicians and others, mental health issues, and the effects of the culture of medicine? One thing to look at is avoiding the workplace drivers of burnout. Some ways to do this are communication at the front lines and having physician and provider surveys that are anonymous, having physicians invest the time to understand and fix work processes themselves, enabling physician leadership to occur, and improving the daily workload by truly operating as a team-based model. In the same book that I was citing from, an example of physician leadership to occur is the Oregon Medical Group, where when a physician or a provider is hired by the practice, there is a compact that's signed by both the provider and the organization outlining the responsibilities of the organization and the provider to each other. An example of the team-based model is the Medical Associates Clinic in Iowa. It's a 170 provider multi-specialty group practice. In this model, that's a team-based model, the nurse or MA completes pre-visit planning 2 to 3 days before a patient visit, reviews the notes, ensures labs are available, identifies any preventative care needs. Then at the time of the visit, the nurse or MA pre-screens the patient, updates the EMR, reconciles the medications, completes the initial HPI, and identifies the chief complaint. During the physician or provider part of the visit, the MA would be the one documenting info into the electronic health record. Then at the end of the visit, the MA can arrange the follow-up visit, submit the request for referrals, etc. Members of the care team also hold a morning huddle of 15 minutes or less to check in. And we'll talk a little bit about the morning huddle later. So I wanted to spend a few moments talking about the patient schedule and strategies to use it to your advantage to avoid burnout. Hopefully, maybe be able to get home more on time. And some of these strategies everyone may already be using or some part of them. But in her book, Rebecca Bernard, she's the author of Rockstar Doctor, she said it's important to assess what type of office schedule actually works better for you. Is it a traditional model with room for 4 to 6 slots versus open access scheduling? If it's a traditional schedule, the retirees love it, but the lots of no-shows can send it into disarray pretty quickly. If it's an open access schedule, working people are going to love it, but it's going to be more challenging for your staff. As she says, don't be afraid to play around with your schedule depending on your patient population and the time of year it is. Is it summer? Is it cold and flu season, etc.? Managing these challenging situations of frequent flyers, no-shows, and overbooking is very important. She suggests managing frequent flyers by scheduling frequent follow-up visits to avoid same-day phone calls and crisis situations coming up, and also to get your anxious people in before you leave on vacation. For the chronic no-showers, it's important to have some sort of a warning letter and then a dismissal letter from the practice if you are able to do that. I know in some situations, I think federally qualified health centers, you're actually not able to dismiss patients. But if you can have some sort of a protocol, that's very helpful with your practice. If you're running late because of overbooking, you really have to employ good staff to let your patients know when they check in. If the schedule is backed up, always offer a reschedule with a plum appointment, which is typically the first of the day or the first afternoon appointment, because those are the least likely appointments where you're going to be running behind. She also says to try to start your day 15 minutes early to create a small buffer zone in your schedule if you're running later in the day, which almost always inevitably happens. And then using your pre-printed schedule for the day, you can write notes for your MA on that schedule. It can be very helpful for you in that way too, to have some printed information in case your computer crashes. She also says to print out the note of when you last saw the patient, because you can use it as a handout for the patient with any changes in medications or directions that you want to give to the patient. So this one may seem like a rather random slide to put in, but it's also important to be able to keep your schedule on track, is knowing how to end the patient visit gracefully. And I think we all get better at this as we become more seasoned clinicians, but there's always those 1 or 2 patients that it's pretty challenging to be able to end the visit. So having prepared statements available is really helpful, such as, we've covered a lot of territory today. Let's set up a follow-up appointment to address any additional issues at the next appointment. If the patient continues to think of additional questions at the checkout that are non-urgent, have them schedule another appointment. And you can use phrases like, I'm glad you mentioned that. I really want to explore it more. Let's schedule a follow-up to give X, Y, and Z the attention that it deserves. So additional ways to lower practice stress and get home sooner. Dr. Drummond, who is a family practice physician, has written extensively on this. One thing he says to do is move from an EHR hater to a power user. I know that I've been guilty of being somewhat of an EHR hater, but he makes the point that EHRs are evolving, but they're not going away. So hating them is not an effective strategy, and it burns a lot of your energy. His suggestion is to become a power user. Find the power users around you, take notes from them. They're the ones that have templates that they've evolved with as they've been working with the EHR. If you have to, ask to shadow them, ask if you can have their templates, and they inevitably say yes. Sometimes if you're not working in a big group practice, you can ask your EHR vendor if they know of who the power user is, and then they can, match you up with that person so you can actually observe how they document. He also talks about making documentation a team sport. Openly ask your staff for help with documentation and see how they respond. It can sound like this. Hey, everyone, I'm working on ways for us to become more efficient at charting. We are a team and all of us chart at some point. What are your ideas about how we can share the work more effectively so I can get from patient to patient more quickly? Another idea is piloting the use of a scribe. You can pilot the use of a scribe. You can agree to take all the risk yourself initially, because a lot of times the complaint is that administration doesn't want to pay for a scribe. So you pay about $25 an hour for the Scribe service. The process would look like this. Get your administration to okay the Scribe, run a detailed production and billing report for your last 3 months. Hire and implement the Scribe. After a 3 to 6 month period, when you feel you and your Scribe are working at maximum efficiency, run another 3-month production and billing report. If the data proves you are now seeing more than enough patients to pay for the cost of the Scribe, ask your particular group to make the Scribe permanent. He also says to look at so-called broken record moments, things that you keep saying or documenting over and over again, and finding ways to template what you can. The patient education part, figure out whether or not you want to write them down and have it as a handout. Figure out if you want to make a video of yourself, and then you can, with educational items that you want the patient to look at, and then you can load them onto a cheap tablet computer that your nurse or MA can give to the patient to review at the conclusion of the visit. You can put them on YouTube, you can give the patient the link, or you can post them in your patient portal for the patient to watch in their office or at home later. Doing the team huddle once or twice a day. That's really important too. Important steps in the team huddle: ask everyone how they are doing. Find out if there's anything going on at work or in somebody's personal life that you need to know about. Know whose kid is sick, whose child got a college scholarship, etc. It's important during the team huddle to say thank you. Acknowledge and thank the members of your team for the good work that they've been doing. Delegate. Encourage your team to be on the lookout for things you are doing as a doctor that they could take off your plate. For example, you can say, we are a team. Caring for patients and completing documentation is a team activity. We share the load. Anytime you see something you could do instead of me, something that would help the team be more effective, please bring that idea to the next huddle. The next step is clearing and centering the whole team for the day. Invite your team to take a deep cleansing breath and become centered before you start seeing patients. And then finally, he talks about batch processing. And I think as doctors, we've all been guilty of this. He relates it to like a Labrador retriever being thrown the tennis ball and just getting continuously distracted by that tennis ball. He relates, new labs coming in to be looked at, that prior authorization, that patient that wants a call back. He says, take all the tasks that are non-urgent and process the batch twice a day at a time when you and the team can address them all at once. In a standard office day, you're going to have a morning schedule and an afternoon schedule. So some good times to do the batch processing is 11:30 in the morning and 4:30 in the afternoon. That way you can wrap up all your morning work or some good bit of it before lunch, and the afternoon's work can be done before you go home. Where are you going to collect the items to be batched? Is it a physical basket? Is it a virtual basket within your EMR that will hold emails or test results? And then who is doing the batch processing? Is that something you delegated, something doing yourself? If you're delegating it, what would be the screening criteria that means that you as the physician would have to get involved? Additional steps to prevent burnout at an organizational level is ensuring that any metrics for an institutional success always include an anonymous physician or provider satisfaction and well-being item. Incorporating mindfulness and teamwork for trainees and practicing clinicians. Decreasing stress from electronic health records. We talked about that a little bit. This is an important one. Covering predictable events with float pools. Allowing some customization of schedules if possible. Supporting manageable primary care panels, staffing ratios, and longer visit times if possible, and addressing career fit so faculty can do what they are most passionate about, whether that is teaching or research or writing or whatnot. So strategies to manage, prevent, and treat burnout on the individual level. One thing that's important is to decide if the burnout is acute or non-acute. This is different ways of working with it, depending on which it is, and using both external and internal strategies to manage feelings of burnout. But I think we also have to talk about why doctors and providers are typically the worst patients, both from a medical perspective and unfortunately a psychiatric perspective too. So possible causes are fear of repercussions from medical boards or employers, the stigma associated with obtaining psychiatric care, a sense of failure of needing help, denial, lack of trust in others, and waiting until one hits rock bottom. So this is a reminder, again, because I love memes and I can't help myself, that it's a self-care reminder. It's okay to fall apart sometime. Tacos do, and we still love them. Some ways to improve psychological health. Some of these may be easier said than done, but exercise, self-care, nature, having fun, spirituality, relationships, and vacation or leisure time. Some physicians find it very helpful to take one weekday off. This may mean that you have to work a 10-hour, 4-day week, but you can take care of your own needs at that time. You can see a doctor, you can see your therapist, you can go to the dentist, whatnot. Additional stress reduction techniques, and some of these may have been talked about before in a prior presentation, but breathing techniques. We know that deep breathing lowers blood pressure, and that's something you can do in between patients. You can do it in the morning or the evening. My smartwatch, actually, I don't like when it reminds me that I've been sitting too long, but I do like when it reminds me to take some deep breaths. Visualization, which is a distraction technique to remove persistent negative thoughts. So one simple visualization exercise is to close your eyes and imagine a train carrying something pleasant, such as daisies. The train actually will push the unpleasant thought that you have off the track, and you can watch the cars go by as the train passes. Open your eyes, and if the thought pops in again, you can repeat the exercise. Stretching and yoga is another stress reduction technique. You may not have time for a whole yoga session during the day or in the evening, but possibly doing a few sun salutations and stretching out in between patients or during your afternoon, your lunchtime break. Positive self-talk, envision positive results instead of negative ones. If you're called in for a meeting with the boss, try to envision a positive outcome of the conversation instead of thinking the very worst. And also venting in a safe way. Some doctors find it really, and other providers find it really helpful to do some journaling or to write something in the notes section of their phone, something that maybe popped in your head that was really bothering you at a certain time of day during your work day that you can then think about later that night and reflect on in a journal. And you can also use anonymous physician sites, such as Sermo is one of those. So we talked about stress reduction techniques, counseling, seeking out counseling, searching out new professional challenges, finding work-life balance, which is something we're going to talk a little bit more about near the end, finding financial balance. Some physicians and other providers become trapped in a stressful practice in order to generate sufficient income to support their lifestyle. So taking a look again at the financial balance in one's life is important. Finding a sense of meaning in one's work, again, is that teaching, is that research, is that writing? And then finally, peer support groups. And I know something that's very helpful to me is that I belong to a social media group that's physician moms. And so we can talk about, parenting and vacation and stressors that come up at work and whatnot. And I really enjoy that a lot. I thought this was funny, back to the meme, and I know I'm guilty sometimes of saying, even if I'm on vacation, you can call me on my cell if it's something urgent. And this is met with no, if there are any of our European colleagues that are listening, this is no disrespect to them, but this says, European out of office, I'm away camping for the summer, please email back in September. Whereas an American out of office, I have left the office for 2 hours to undergo kidney surgery, but you can still reach me on my cell at any time. So we talked earlier about how women are specifically at an increased risk of burnout compared to men. Studies show that the odds of burnout are 40% less for female physicians when they have the support of colleagues, spouse, or a significant other. Supportive work culture can mitigate some of the challenges of achieving optimal work-life integration. Seeking help from a therapist, Because many women clinicians experience unique pressures related to balancing personal and professional demands, organizations can foster balance by promoting gender-specific mentorship programs and implementing policies and practices intended to improve work-life integration for women. And then I wanted to talk about Dr. Drummond. Again, he's the family practice physician who's written extensively on burnout. He talks about 4 tools that you can do to find the work-life balance. And I actually, I really liked these. I thought a lot of these were really helpful and maybe something that I would implement too. The first tool is the life calendar. I think most of us have a planner, a calendar in our phone, or something that we have to organize ourselves. But he talks about first, build your life calendar for the week ahead. Pick a time of the week where everyone in your family or household is available. But you also need to factor in some things for yourself, such as workouts, time for writing or journaling, free time, coffee with a friend or a relative, time to read a book, a class, whatever you want has to physically go on the calendar. The second step is to take a picture of your life calendar with your cell phone, and then you can carry it around with you everywhere. The next step is to defend your life calendar. Now you have to be prepared to say the magic 2-letter word that is key to work-life balance: no. If you're already booked, you have to learn to say, I'm sorry, I have another commitment at that time and I won't be able to help. If you're like a lot of us, you may be horrible at saying no. Reasons that doctors and other providers may be afraid to say no is because we don't want to be perceived as not being a team player or being weak, imperfect, or unable to do it all. But we have to let go of that in order to take care of ourselves. The second tool is intentional date nights. If you don't have a significant other, a date night could be spending time with a friend, someone you'd like to know better, or doing something nice or unexpected all by yourself for yourself. Take turns planning your date nights, but keep your plans a secret. Only reveal when to be ready and what to wear. Write down several date night ideas on a slip of paper is another way that you can plan them. Drop them into a hat and pick one raffle style and go for it. Or buy tickets to do things in bunches, such as if you love pro basketball, season tickets to the Washington Wizards, etc. That kind of makes it sort of a no-brainer to be able to plan out a bunch of date nights if you've already bought in bunches. On any date night, even before you order drinks or appetizers, your first step is to schedule the next date night out. Instead of putting just the next date night on your calendar, schedule out 6 date nights, 3 months worth. The next tool is talking about the big bucket and the weekly bucket list. I think we all know what the big bucket list is. These are the items which would break your heart if you had to think about never being able to experience them. First, you need to schedule them. Pick a first big bucket list item. Look on your calendar as far as you need to in order to find a time that will actually work. It could be 1, 2, or 3 years out from now. Schedule it anyway. Go into work, block off your schedule on the work computer, put your stake in the ground. It may be something you schedule for one time period only, such as a trip, or it may be something you have to schedule regularly, such as writing a novel. Next, you have to put skin in the game. Buy the tickets, order the resources, book the cabin, put the money down immediately. If you can't make the purchase yet, open a savings account and start putting money away for your big bucket list items. Whether it's Machu Picchu, Africa, the running of the bulls in Pamplona, visiting the country of your family's origin, get it scheduled, paid for, and put it on your calendar. Then he also talks about the weekly bucket list. So in the weekly bucket list is that one item or activity or experience that really just turns your whole week around. This may be working out, getting a massage, a dinner with a friend, playing music, possibly religious practice or meditation. So you need to think about what your weekly bucket list items are that recharge you. It's so important to take care of yourself, and it can give you the energy that you need to actually be able to take care of others without getting burnt out. And finally, there's the tool of the work-life boundary ritual. So I know I'm guilty of this, but have you ever found yourself sitting at home thinking about work or one patient that you just can't let go of that you keep thinking of? the problem is that we have never been taught the off switch in our roles as doctors or providers. And you can't recharge in that situation if you're continually thinking about work. Instead of recovering, you are still drained by work stress, even though you are not in the office or the hospital. Creating that boundary ritual is a mindfulness skill you have to learn to do and practice. We have a great model of boundary ritual, Mr. Rogers. And his boundary ritual was taking off his jacket and putting on the red zip-up sweater that we're all familiar with. He changed his shoes. He sang "It's a Beautiful Day in the Neighborhood." When his boundary ritual was complete, he was able to be the Mr. Rogers that we know and love for the rest of the show. So finding your own boundary ritual. For me, sometimes I stop for a cup of decaf coffee on my way home from work. The most effective rituals are going to involve three things: an intention to let go of work, a few deep releasing breaths, and an action. Is that changing clothes? Is that walking the dog? Is that taking on your contacts, putting on glasses, putting on some comfy clothes, or making a nice dinner for yourself? And finally, if it's acute burnout, it is no amount of yoga or meditation is going to extreme time management will save us from the effects of extreme work and extreme burnout. Possible things that you can do for that is time away from work. This may involve a paid or unpaid leave of absence from work, taking extended vacation time, or medical leave. Professional assistance is another way that you can treat acute burnout. One resource that I have here is the Federation of State Physician Health Programs at www.fsphp.org, and the Sodile Center for Physician Resilience. Dr. Sodile uses his own training in family systems to work with physicians and their families who are experiencing burnout. And finally, finding a professional coach. Oftentimes, this is a fellow physician or provider. Professional coaches can help with issues related to time management and delegation. Dr. Mudge Riley, who's a professional coach, stated that coaching offers support and mentorship. About 1/5 of her patient population, which is physicians, chooses to leave medicine altogether, but the rest can find space for other endeavors such as starting a business, quality or regulatory work, medical writing, or fiction writing. And these are my references. Anyone wants to read through them? Right at the end.
Thank you so much, Dr. Booth. We will be sharing these slides with you all after the presentation. The recording as well will be available on our website later this week. But we'll go ahead and move into our question and answer portion. So if you do have any questions, please place those in the chat or the Q&A, whichever is easier for you. And Dr. Booth, if you want to take your slides down, I think you'll at least be able to see me if you'd like to. So it's a little more like we're having a conversation, and I'll read the questions as they come in. Just a few more housekeeping notes. If you're attending today for CEU or CME credit, we will have you complete an evaluation, which will be placed in the chat in a few moments. I'll also send it out over email so you don't miss that link. But please do give us your feedback. We appreciate that. And if you're active on social media, we put our social media information in the chat as well. And you can feel free to share maybe something you learned today. We like to spread the knowledge for others that weren't able to attend and get these strategies out there to avoid provider burnout. But thank you again, Dr. Booth, for covering this really important topic. It's something that we don't always make time for, but it's definitely really valuable and something we need to focus on more, especially during COVID in the last few years. So we do have a couple questions that we can go ahead and start with, but I'll be watching the chat as well for any other questions that are coming in. First question here, what are strategies that you recommend for checking in with yourself? This is something I wonder because sometimes it seems we don't notice how near we are to burnout until there are significant signs.
Well, I mean, I can say that for me personally, I think writing things down is real. First of all, I should say I focus on both the physical and the psychological signs. So I will get, when I'm so tense, I will get where I'm almost breath holding. So again, I love my smartwatch because I'm like, oh my gosh, I can almost feel that, like that pit in my stomach, and that like I am not releasing air here. I'm not breathing as a normal human should be because I'm so like tense and on. So I think for one, it's listening to the physical signs in your body. And again, I don't like that my smartwatch taunts me with the, you've been sitting too long, but I do like that it'll say, take some neat, like nice deep breaths. If you're feeling, so if you feel physically, you're having physical signs, more headaches, more stomach aches. I think those things are a sign that something really is going on there. And then I think from the psychological perspective, being able to, I don't know that I full on keep a journal, but I do write things down sometimes in the notes section of my phone that no one's ever going to look at, that I'm like, okay, I was really angry in this moment, or I was really frustrated. Like so intentionally checking in with yourself at the end of the day. I think, as part of my, like, and I don't always do this, but as part of my meditative practice, there's things that I'll do where I'm always at the end of the day trying to check in and say, these are the things that I'm really grateful for in my life or that happened, like expressing gratitude. But then what are some items that really ticked me off today, or some, and then if you've actually physically written that down somewhere, because sometimes these thoughts kind of pop in our head and pop out, it may be easier to have some sort of actual, physical representation of what we were thinking in that moment, so we can deal with those. You may not be able to deal with those thoughts as you're moving from patient to patient. You're in a very, very busy practice. I mean, my brother is a internal medicine doctor, so he's pretty busy all day, and if you can just, at least at the end of your day, um, be able to check in with yourself in that way.
Yeah, wonderful. So just making that intentional space. And I would like to just celebrate everyone that took the time to come today, because that shows that you're taking that step there as well. So thank you for coming. We do have another question here. How do you suggest maintaining a work-life balance when working from home 4 to 5 days per week?
So I pretty much exclusively work from home now, and I think that that is a really unique challenge, with COVID. I can say that, especially as a mom, you can get pulled in a lot of direct, and it's harder because the whole, I was speaking about the work-life boundary, but that's a lot harder to do. When you're working, from home, it's a lot harder to make those separations. I mean, some things that I have found, and in some ways during the height of the pandemic, I was taking some notes from my husband, who had to work from home too, but he would actually like dress himself up as if he was going to work. And at first I was like, what are you doing? Like, what are you doing putting your badge on? And by dressing up, I don't mean that you have to like have some extensive, morning routine, but he was going through, and he doesn't wear a suit to work, but he was changing into, things that made him feel more in a work environment. And then having obviously, as physicians or providers, we have to do this anyway, having a dedicated workspace. And I find, like, actually physically, like, not letting my notes, like not letting anything leave that workspace, not be tempted to like work on my notes in bed. Or I think that if you can carve out the physical space in where you're living, that's helpful. I think if you can try to intentionally, you know, like make yourself up in a way that you are going in, and then still have that ritual of where, okay, I'm done, I'm gonna and for me with the telepsych, a lot of times what I'll do to sort of regroup myself again is I'll either take my dogs for a walk, or I will go for a run, or I'll do something that is going to create that boundary. I might not be leaving work in the sense of driving away from it, but there's some sort of creation of a boundary still occurring there.
Yeah, wonderful. That's very helpful, concrete advice there. Um, so another question, what should providers do when they are in an environment with other professionals that are maybe resistant to implement changes um, at that specific practice that would help avoid provider burnout? So maybe such as changing schedules, like you had mentioned earlier.
Yeah, the question is, would that be something that's coming from the administrative end, or something that's coming from like co-colleagues? I guess it would kind of depend on the situation. I mean, I think, if there's some resistance, maybe even a way of being able to, kind of anonymously survey people to sort of see where people's thoughts are, maybe anonymous surveys on people's mental health and wellness, so you can kind of check in and see where that practice is at. And then if there's, disclosure of the results, not who specifically was responding, and you can kind of take the temperature of the mental health of that group. If you can make the argument for that and you see that it's pretty low or not where you'd like it to be, then that can be an argument for making these kinds of changes, because as doctors, we want, providers, we want that like physical, cold, hard evidence. That's the same thing that when I was reading about piloting the use of a scribe, and a lot of administrations don't want to do it. So you almost, with that sort of a situation, you kind of have to take on the onus of the of the financial burden for a couple months yourself to prove. But it may be the same sort of thing with that you may have to find like a physical tool to say, hey, we're not doing as well as we could be. And these are some ways that we need to kind of work on this and figure this out, because we love numbers, and we love surveys, and we like the cold hard evidence.
Yeah, that's wonderful. So just a note as well for everyone, we have put the evaluation link in the chat, so you can go ahead and copy that down before the end of our session today. We'll move on to another question. How can we support colleagues who we believe may be experiencing burnout, and what are some of the best ways to have those conversations?
I think that obviously some of that is going to depend on your level of your, relationship or friendship with that colleague. There is actually a toolkit list put out by the American Medical Association. I think it's on burnout and the risk factors for depression, even suicidality, that you can look at and download. I didn't include that on my slides. But I think, sometimes when I've sort of seen that a colleague might not be doing well or something, sometimes you can bring it up if you can bring it up in a non-threatening way, like, even sometimes like grabbing a coffee outside of work, or, and then, sort of leading someone into it open-ended. I think, Rebecca Bernard talks about in her book about just how to be a rock star doctor, and we've talked about this, I think, in a lot of different ways, but destigmatizing, mental health care. If somebody brings up, maybe I should see a therapist, then you can kind of tongue in cheek be like, well, who isn't? Or, kind of like that, and normalizing that, you don't necessarily have to see a therapist for some horrible life event. It can just be part of your self-care, like going to the gym. The more we can normalize that and say, well, who isn't? Well, you're not, you're not in the loop. You're not, I think that really helps.
Yeah, I appreciate what you've said about coming at a non-threatening way and just trying to normalize it. That makes a lot of sense. So what would you recommend as first steps to take in improving workplace practices to avoid burnout? And we've covered a lot of ground today, but what would you say those first steps would be?
I think the first steps again would be, really checking in with your staff to see where they're at. I think too I didn't speak specifically to the pandemic, but and I kept wanting to pull some literature specific to that, and I'm sure we're going to be seeing that and talking about it for a really long time. But I think taking the temperature of psychologically, where your practice is, and is this something that people can talk about openly, or is this something that takes an anonymous, people hate surveys, but kind of an anonymous forum, because I think that's the step towards identifying. I really like the idea of daily check-ins too. It's been a long time. I haven't rotated in primary care, pediatrics, or internal medicine or family medicine since I was a medical student, but I don't remember, and it may have been that I came in later, in the morning, but I don't remember the team huddle. I really liked that idea. I really liked the idea of finding out where your practice is just overall, where the headspace is, but then also checking in daily in a way, and trying to take care of everybody's mental health on a daily basis in a team way. Like, we're all in this together. Let's take some nice deep breaths. Oh, so and so's on the schedule. It's going to be kind of a hard day. Those are times that you can talk about that. Is during your morning huddle, and I think that's really important.
Yeah, wonderful. Yeah, we have a comment here in the chat that this provider was a therapist in a pulmonary clinic and the huddle was invaluable. So just more approval of that process. I'm not seeing any more questions at the moment. We do have a few more minutes left, so keep those coming. Just as another note, the CME and CEU certificates will be sent within 3 business days after you complete that evaluation, which again is in the chat, but I'll send it over email so you don't miss that. We do include information about the recording and the slides and also related resources. So Dr. Booth, I can hunt down that AMA toolkit on burnout, and I'll include that as well so that everyone has access to that. And our next BHIPP resilience break is on types of mental health evaluations and when to recommend them. That'll be presented by Antonia Gerard on June 21st. So please save the date there. We'll be sharing registration information for that soon. And again, our social media information is in the chat. If you want to share anything that you've learned today to continue to spread this knowledge, we appreciate that. And you can be entered to win a free BHIPP water bottle. So something back to you as well. Well, while we have a few minutes, is there anything, Dr. Booth, that you would like to leave our attendees with today?
Let me think. I think just, with the pandemic, I think everyone felt the stresses of trying to practice self-care, and back to my meme of I love Mexican food. So, it's okay to fall apart. It's okay to take care of yourself, and it can be really small things. I was talking about my brother who's an internal medicine doctor, and we were doing during the pandemic because we were, he was afraid to get me sick, and we bring that back to my family because he's in a practice. So we would be doing our little, like, we call them car coffees, where we would collectively each sit in our own car with our Dunkin' Donuts coffee, but then pull up, within like keeping social distancing in our car. But just finding those avenues to check in with each other, check in with yourself, and be okay with needing self-care.
Wonderful. Well, thank you so much for your time today. I'm not seeing any other questions, so we'll go ahead and conclude our session, but we really appreciate it. Thank you, Dr. Booth.
Thanks.
Thank you. Bye.
Bye.